Hello, everybody. Welcome to Unit 3. We're almost there. All right, we're going to keep going with ischemia in the heart. And here's our next case. So this is kind of in the middle of a note page because obviously case 17 was on your previous exam. So your patient is a 57-year-old advising executive who was admitted to the emergency department at 3 a.m. following 1.5 hours of severe, unremitting precordial chest pressure. He was admitted to the cardiac ICU to rule out a myocardial infarction. So a myocardial infarction falls under that kind of big umbrella term of acute coronary syndrome. Now, when you get a case like this in the middle of your cardiopulm class about someone who's showing up to the emergency department with unrelenting chest pain, it can feel kind of maybe rather obvious that this might be an acute coronary syndrome or a myocardial infarction. But I just want to put it on your radar that there are about 6 to 7 million patients that present to the emergency department with chest pain or symptoms that would strongly suggest acute coronary syndrome per year. And only 20 to 25% of those people will be diagnosed with unstable angina or MI. So these are symptoms that you need to take extremely seriously and seek medical attention. But do know there's many times when someone will present with chest pain. In fact, more often than not, it would not end up being acute coronary syndrome. Let's just review kind of what's happening here. And you have space in your notes to kind of draw with me. And we just do a little bit of a reminder from PathoPhys about this acute coronary syndrome. So this should resemble kind of the drawing at the bottom of your note packet. So if we want to really kind of go through what's happening in acute coronary syndrome, well, most often somebody who experiences unstable angina or myocardial infarction will have had underlying coronary artery disease. So this vessel that is perfusing the heart tissue does not look like the one that's in your notes, this pretty open vessel. It would have atherosclerosis. So if we kind of draw in some atherosclerosis, let's first draw in some of those vascular smooth muscle cells that proliferate and migrate into the lumen. And you could draw those on both sides, creating the atherosclerotic plaque, which means inside here we have a lipid core. So here is our lipid core. And if you remember from PathoPhys, the reason you get the atherosclerosis, right, is because the LDL crosses the membrane, crosses the cell layer, becomes oxidized. It's phagocytized by macrophages that have been able to move out of the lumen of the vessel and move into that space beyond the endothelial cells. And once the macrophage eats the LDL, it creates a foam cell. The foam cells accumulate. Foam cells end up dying and just leaving the fat behind, and you end up with this lipid core. So the lipid core is held in place by vascular smooth muscle cells and, what color should we make it? Maybe gray, and some extracellular matrix. So some scarring has been laid down. So this gray here is some extracellular matrix. And the vascular smooth muscle cells with the extracellular matrix is the fibrous cap. And that fibrous cap holds the lipid core kind of in place. So this causes problems, of course, because the diameter of the vessel is narrow. So blood going through this vessel is limited because of the atherosclerosis. And an individual who has a vessel like this might have been experiencing stable angina, that whenever they increased oxygen demand of the cardiac muscle, the very narrow diameter that's available was insufficient to deliver that oxygen, and they might have had some ischemia. When someone experiences, I'm just going to take this off to keep my picture as clean as possible. When someone experiences an acute coronary syndrome, most often there is a rupture of the fibrous cap. When the fibrous cap ruptures, or in some cases can be eroded away, you release the lipid core into the vascular space, into the lumen. And the lipid core is extremely thrombogenic. So if you have a rupture, so we'll kind of draw this sort of exploding out, and lipid core can leak out into the lumen of the vessel, this is going to instantly activate platelets. Let's see, let's make these a color that will stand out here, maybe orange. This is going to activate platelets to start the platelet activation process and form a clot. So we're going to get platelet aggregation and accumulation. We're going to start laying down fibrin to stabilize this clot. And you go from a reduced diameter to a complete blockage. So when the fibrous cap ruptures, you get platelet activation and clot formation. This is why it is a sudden event that changes so dramatically, because you went from a reduced diameter to a complete blockage. And when you have this complete clot formation, this is going to result in ischemia and infarction. So if we look kind of over to the right-hand side, this is a cross-section of the heart. And the orange box shows kind of what we're zooming in. So if we zoom in on the wall, these two, it's like C-shaped line on your graph is meant to be the wall of the ventricle. So this on the, let me make this maybe gray. So this is your ventricle chamber here. So kind of this same area here. So this is the chamber that's holding all the blood that's being pumped through the body. The inside layer here, this is the endocardium. It's the inside surface of the chamber or the ventricle. This is the area of the heart wall that, kind of interacts with the blood. This outside line is your epicardium, the outside of the heart. The coronary arteries that perfuse the myocytes that live in this heart wall, the coronary vessels run along the outside. So let's draw in a coronary artery. So here you have the coronary artery that's going to perfuse the ventricular wall. Sorry, I keep putting my do not disturb on, but it keeps making that noise. And the area, kind of anywhere in here is going to be perfused by this coronary artery. So when you have a sudden rupture of your fibrous cap that leads to a clot being formed, you are going to suddenly occlude this coronary vessel. And if it's a partial obstruction where there's some blood flow, it means there's going to be areas of this ventricular wall that are not going to get enough oxygen. The farther away you are from the coronary artery, the more susceptible you are to ischemia and eventually cellular necrosis because of insufficient blood supply. So the farthest away is going to be your endocardium. And this is where we're going to start to see necrosis or cell death. So a partial obstruction will lead to cellular death within the ventricle wall. And the further away the cells are from the blood supply, the more affected they're going to be by that occlusion. The other option, and I can just draw kind of a second version of this where the coronary artery is out here. If you had a complete occlusion where the clot completely blocks all blood flow, then any part of this ventricular wall that was being kind of fed oxygen from this vessel, it would all undergo necrosis. So when you get a complete block, that's when you can end up with a full thickness myocardial infarction, where the death goes all the way through the ventricular wall. Let's go back to the PowerPoint slide and look at kind of the cartoon image of this. This image shows 3 hearts on the bottom, showing what it looks like 1 hour into the myocardial infarction, 4 hours into the myocardial infarction, and 8 hours. The yellow is your zone of ischemia. That is where there is myocytes that are getting insufficient amounts of oxygen, but they are still alive. So the blood flow is reduced, but there's enough oxygen being delivered for those cells to live. The purple is the area of actual infarct, and that is where there is cell death. And you'll see that as time goes on, that area of infarct gets larger because cells can live for a while in an ischemic state, but they will quickly find themselves in a position where the oxygen levels are insufficient. Arterial reperfusion within 20 minutes, and you can prevent necrosis. So when people say time is muscle, it is if you can act quickly at the earliest signs of evidence of an acute coronary syndrome, if they can reperfuse that vessel, they can actually prevent the cell death from happening. Part of the reason that this infarct area, the purple circle on these hearts, gets progressively bigger is you do end up in a vicious cycle when you're experiencing a myocardial infarction. As a small area of the heart is infarcted, that the wall of the ventricle will become weaker. So while those cells are undergoing cell death, or even those cells that are ischemic, they might not be functioning at the highest strength they could possibly squeeze at. During the myocardial infarction, you can get a decreased stroke volume, kind of secondary or from the damage that's actually undergoing in the heart at that time. But as you decrease stroke volume, that means you're pumping less blood into the periphery. As you decrease stroke volume, you decrease aortic pressure. And here's the vicious cycle. The aortic pressure, the aorta is the source, right, that gives rise to our coronary vessels. So as you're pumping less blood into the aorta, you are actually pumping less blood into the coronary vessels. So you get decreased blood flow to coronary arteries. Well, this is going to worsen the ischemia. And as the ischemia gets worse, you get more damage and you get reduced stroke volume. And now you have this vicious cycle of progression that as the heart gets worse, it's getting worse and worse at delivering blood flow to itself and making the damage become more severe. So part of the growth in the area of infarct is simply just time in ischemia, that the longer a cell is depleted of adequate amounts of oxygen, it gets more and more likely that it will die. But the second piece of it is that because the heart is pumping blood to itself, as the heart gets weaker, it speeds up the problem dramatically. So if you go to the top page of the next side of your notes, there's just a big open space. And I'm going to kind of go through the steps that are included in the assessment of acute coronary syndrome. And this is a very similar kind of flow chart that we had done in PathoPhys, but it's good to have it right here when we're talking about this in our our class, we're actually talking about treating patients who have these conditions. So acute coronary syndrome is a big umbrella term, and it really only means that you have chest discomfort for more than 20 minutes. So it's kind of an umbrella term for blood supply to the heart has suddenly stopped. First clinical symptoms, are going to include signs of myocardial ischemia. But under the umbrella of ACS, there are a number of different actual things that can be going on in the heart. Included under acute coronary syndrome is unstable angina, so stable angina, which we talked about in the previous case, is when you get signs of cardiac ischemia to a known stimulus. Every time I walk up the stairs, I get a little chest pain, but if I take a break at the top of the stairs, it'll go away. Kind of classic stable angina. Clinical signs that would suggest that it's unstable angina is chest pain for more than 20 minutes at rest. So that's how it falls under the acute coronary syndrome. They have chest pain for more than 20 minutes at rest. If the chest pain is new and much more severe, it's like a severe onset compared to their normal stable angina. And it can fall under unstable angina when the symptoms of angina increase in intensity, duration, or frequency. So unstable angina is a sign of an acute disruption in blood flow. But if we drew this out, I'll draw it kind of at the bottom. If we draw that ventricular wall with the coronary vessel, there is a partial occlusion, but the occlusion is so small that you are able to keep the cells of the ventricular wall alive. So while it is a sudden change to the blood flow to the heart, there is no infarction. So there is no cell death in this area. The portion of the ventricle that's being supplied by that vessel, those cells are able to stay alive. This is what separates unstable angina from a myocardial infarction. So under ACS, you can get a subendocardial MI, that is cell death of that innermost area of the ventricle. This is also what we refer to as a non-STEMI, which we talked about in the EKG lecture. So if we redraw what's happening in the subendocardial MI, you have the coronary artery with a partial occlusion. And I am attempting to make my picture look a little more occluded if you compare these two coronary vessels between the two of them. The occlusion is a sudden onset, a sudden change in blood supply to the heart. But this is the area where you get cell death in the tissue that's farthest away from the blood supply, which is going to be your endocardium. So you get endocardial necrosis, cell death in an area of the ventricular wall. And then the last one would be a transmural MI. And that kind of looks sloppy. Transmural, there we go. And these would be our STEMIs, our ST segment elevation myocardial infarction. If you do the same picture, coronary artery, this is going to be a complete blockage. So with a complete block, any area that was getting blood supply from that vessel is going to experience cell death, and you get a transmural infarction. Okay, so this is just the groundwork for the three types of scenarios that can be taking place when someone has acute coronary syndrome. So someone shows up to the emergency room like our patient did in this case. The first thing they're going to look at is their clinical history, kind of what is the nature of their symptoms, if they have any history of coronary artery disease, looking for cardiovascular risk factors like their age and their gender, and kind of keeping a tally of other risk factors, smoking, obesity, lack of exercise, all the classics. Then they're going to begin a physical examination. And as they're doing this, they're very quickly going to be putting EKG pads on. The physical exam is going to be looking for diaphoresis, looking at the nature of their skin. Is it cool? Is it pale? Looking at vital signs, like if they're going into tachycardia, listening to the heart for those possible other heart sounds, listening to the lungs, measuring their blood pressure. And this is all going to help to feed into the clinical picture of what's going on. As soon as those EKG pads are on, they're going to start getting an EKG reading. And they're looking for evidence of myocardial damage. So if someone is experiencing unstable angina, this would be signs on the EKG of myocardial ischemia. So you can see with unstable angina, ST segment depression, a sign of that cardiac ischemia. There may be evidence of T wave inversions, showing an acute change in the blood supply to the heart. This could be evidence on EKG of unstable angina. But if you look at what's happening in the subendocardial MI, there's a lot of area of ischemia as well. So the EKG looks very similar between these two. You can expect some ST segment depression. You might see that same T wave inversion, the classic sign of ischemia, kind of very sensitive measure of ischemia. But because this is not a full thickness myocardial infarction, you would not expect to see ST segment elevation. That is when we get to the transmural MI. The classic finding here is ST elevation, which is actually what it gets its name when people refer to a STEMI. In a transmural myocardial infarction, that's when you can see those abnormal Q waves, those big, exaggerated, kind of deeper waves than you normally expect. So they're getting clinical history, they're doing a physical exam, they are getting EKG findings, and they are drawing blood to quickly evaluate if they have cardiac biomarkers present. So at the bottom of these notes, there's additional information about cardiac biomarkers. So let's step out of our flow diagram for just a minute and review our cardiac enzymes, and then we'll add them back into this figure. So as a reminder, the blood work is looking at what's circulating in your blood, and they're looking for enzymes and proteins that should normally live inside of a cell, inside of a cardiac cell specifically, and should not be floating in your bloodstream. The only way an intracellular cardiac enzyme or protein is floating in the blood is if there was disruption of the cell membrane that released these intracellular markers. So if cardiac enzymes or proteins are found in the blood higher than would be expected, this is a positive finding for cell death in myocardial tissue. So the first one that's on your list is troponin. And when they're looking at troponin, there is specific troponin isoforms, T and I, that are only found in cardiac myocytes. So these are the preferred marker because they're extremely sensitive and specific for myocardial cell death. So this is kind of the gold standard for the diagnosis of myocardial necrosis. The negative with troponin is it can take a while before it accumulates in the blood. So it can take, almost 6 hours after the injury before troponin is circulating. So our guy in our case showed up to the ED after an hour and a half of chest pain. If it takes about 6 hours for enough troponin to circulate to truly get a positive finding, that might not even be there yet. So if you take the blood right away, troponin might not yet have had time to elevate. The other negative is, and you can see kind of, so here's troponin on this graph. You can see it takes a little while to get your peak, and then it takes a while to wash out, because this is days after onset here. So it stays elevated for a while. So troponin is not the best biomarker to detect reinfarction. Like, you could be in the hospital, potentially have another event, and troponin hadn't gone down yet, so it can kind of hide the second infarction. The nice thing, the big pro about troponin, as it says the next point in your notes, it stays elevated for 5 to 14 days after injury. So this can be helpful if somebody doesn't seek medical attention right away and they come in later. That might be circulating evidence of an MI several days after the attack, which can be helpful. The next biomarker on your notes is creatine kinase or creatine phosphokinase, just depending on how it's described. This is another enzyme that can be detected in the blood, but unlike troponin, this typically accumulates quicker. So within about 3 to 6 hours after injury, but it peaks at about 18 to 24 hours. So not a huge difference there. It is highly sensitive marker, but it's not very specific, as there can be other creatine kinase, like for example from skeletal muscle. So CKMB is a specific isoform that's released from the heart, but that makes it not quite as strong of a marker as troponin. It does have a very short half-life, so creatine kinase is a much better biomarker for reinfarction. It's typically normal in about 2 to 3 days that your body is able to clear that out. Myoglobin is often assessed, but it's very sensitive. Like, myoglobin should not be circulating in the blood, but it has a very low specificity because it's the same protein for skeletal and cardiac tissue. So basically, myoglobin can help rule out an MI, because if you're having an MI, it really should be there. So these are the main markers that you can use when someone is showing up and you're trying to confirm whether or not they're undergoing acute myocardial cell death. So if we go back to our flow diagram, the 3 different kind of versions of myocardial ischemia that can be happening during acute coronary syndrome. In unstable angina, if you draw blood, there's no infarction happening, meaning there's no cell death. So in unstable angina, you would not expect to find biomarkers. There should be no circulating cardiac enzymes or proteins because there was no cell death in unstable angina. So there is clinical signs of chest pain or other related signs of myocardial ischemia. There is evidence of ischemia on an EKG, but no circulating biomarkers in unstable angina. When you get to a non-STEMI or a subendocardial MI, there is necrosis that happens. There's cell death. So any cells that are in that subendocardial region are spilling their intracellular enzymes and proteins into the blood. So the non-STEMI, you would expect for biomarkers to be present. So this is our first way that we really have divided unstable angina from subendocardial MI, in that these two might present with very similar clinical symptoms. They might look very similar on a EKG, but circulating markers would set these two apart from each other. And then in the final case, the transmural myocardial infarction would have lots of cell death because it's a full wall thickness. So you would expect biomarkers present. So to discern between a subendocardial MI and a transmural MI, they would both have circulating biomarkers. In general, you have a higher concentration of biomarkers with a transmural MI because there would be more cell death, but that's not always true. And it can vary from person to person dramatically. So that's not a hard and fast rule, but it would make sense that if there's more cell death, there could be a higher amount of biomarkers in the blood. But these two conditions look very different on the EKG because one has signs of ischemia and one has evidence of a true full thickness infarction. So if we go back into our PowerPoint slide, this is kind of the clinical approach. Gold standard would be the troponin assessment. So they'll immediately draw blood and look at troponin. If no troponin is present, that does not rule out an MI. They would then look at the creatine kinase, the EKG findings, and correlate that with their symptoms to try to make a diagnosis. So here is the evaluation in the cardiac ICU. This patient's blood pressure was 110/72. His pulse was 88 and irregular. His lungs were clear to auscultation. That means there's no abnormal findings. They report no abnormal heart sounds, specifically no S3. And you can see the cardiac biomarkers as evidenced there on the slide, elevations in CPK and troponin. This is the patient's EKG findings. I'll kind of draw your attention to some of the findings. On lead 3, we can see an early ST segment elevation and some Q wave formation. At the AVL, you can see some ST segment depression and T wave inversion. So we've got evidence of both infarction and myocardial ischemia. From these findings, the patient was ruled in for an inferior wall MI. He was treated with tissue plasminogen activator, TPA, and glycoprotein 2B3A inhibitor. So you can see that the benefit of the 12-lead EKG really helped to specify the location of the infarct. That's why they're able to say inferior wall, because leads 2 and 3 and AVF had some evidence of the infarct, whereas the AVL was showing the lateral wall, which is where there was some ischemia but not infarction. The goal here with the treatment, when someone is diagnosed with an MI, there is a goal to have thrombolytics within 30 minutes of entry into the hospital. The quicker you can start to actively break down that clot, the quicker you can get reperfusion. And again, as we mentioned earlier, if you can get arterial reperfusion within 20 minutes, necrosis can be prevented. And then the sooner you can get reperfusion beyond that time, you can limit the amount of cellular necrosis or the area of infarct. Let's take a look at the drugs this patient was given. Tissue plasminogen activator converts plasminogen to plasmin. And plasmin is the element that directly breaks down the fibrin of the mesh clot. So it kind of is like a scissors that goes in there and just starts cutting all those little pieces of fibrin. So this is a drug that's actively going to break down the clot. The adverse effect, the negative of TPA, is it can cause bleeding because of this ability to break down fibrin. So that's always a concern, but it's kind of a risk-benefit decision, and to get that reperfusion to save the heart kind of outweighs the risk. When somebody has unstable angina or even a non-STEMI, they can sometimes be treated with an anticoagulant only, because our body will naturally break down a clot. So if you can stop the clot from getting bigger and allow the body to break it down, if it's not a complete occlusion, They might value kind of not putting on that bleed risk if they think there's a chance the body will break it down in its own time. They also added in glycoprotein 2B3A inhibitor because it's a potent inhibitor of platelet activity. I included in your notes some of the more common names for this inhibitor that you can see when this drug is brought on board. So this patient had 36 hours in the cardiac ICU, which were unremarkable, meaning no big negative thing happened. And he was subsequently transferred to a private room, at which time he was referred to physical therapy for cardiac rehab. So we went through cardiac rehab in physiology of activity, but as a reminder, this is a multidisciplinary approach between lifestyle intervention, exercise, the medical team, to try to make long-term changes to keep patients healthy and prevent recurrence of these adverse effects. I included in your notes a little bit more specifically the generalized goals of cardiac rehab, but this is all kind of a review from phys of activity. So cardiac rehab, again, is broken into 3 phases, phase 1, 2, and 3. 1 is typically what we consider to be inpatient care, and that can be anywhere from 3 to 5 days. The average length of stay after an uncomplicated MI is 3 to 5 days, which is kind of where that number comes from. The specific goals of phase 1 are, I have that listed on your next page. Let's just go through this before I flip to your next page. So phase 2 is what happens immediately after they're discharged, and that typically lasts about 12 weeks. And then phase 3 is really long-term care, long-term lifestyle changes to keep that patient healthy and maintain cardiac health. So our patient was referred to phase 1. So the specific kind of goals here are to assess their clinical status, get immobilized, make sure they understand kind of what their risk factors are, what brought them in, why this is happening, so they can make changes to their lifestyle or begin the process of deciding if they want to make changes to their lifestyle, and then discharge planning with what they can do with physical activity and already trying to set up the referral for cardiac rehab. So for our patient, we're going to be seeing this patient on day 2 after their MI. You're going to do a thorough chart review. You see that the patient's time in the CICU was, good. No ongoing chest pain, no arrhythmias, no evidence of congested heart failure. His latest EKG shows significant Q waves in leads 2, 3, and AVF. That's kind of that permanent EKG scar that's going to be present to show the history of that full thickness inferior wall MI. They're continuing to draw serial troponins, and you can see here that they are elevated beyond normal, and they're elevated into a severe MI, but the number is going down. So the dates aren't on this little summary, but you can see that it was going up, and then it began to go down, go down, go down. And that is all you need to feel confident in treating patients limited to the rules around lab values. As long as those troponins are trending down, that is evidence that the injury is over. It will take a while for your body to clear that out, right? You have to basically filter the troponin out of your blood and ultimately pee it out. And that will take a while, which is why troponins can stay elevated for a while after the MI. So you would never, it's not appropriate to think you would wait until they're completely gone, because mobility is so critical for patients, and getting some cardiac demand during the healing process is really important. So as long as they are trending down, you should feel confident, at least in that lab value, for making your decision to treat. The patient is put on beta blockers, which is a goal to help protect the heart during the phase of healing. So I included this chart of the common medications that are used for cardiac dysfunction and kind of why they're on board, because that was a nice way to put it all together, because we've heard a lot about each of these already, but you can see kind of different versions, combos of these with a specific patient. NTG is that nitroglycerin, which is a big venous dilator, trying to decrease venous return, unload the heart, decrease the work of the heart. Calcium channel blockers work directly on that calcium release, so it can actually decrease the force of contraction of the smooth muscle cells. That can open up the vessels, the coronary arteries, the pulmonary arteries. Beta blockers block beta adrenergic receptors, so the goal there is decreasing the work of the heart. Very similar with ACE inhibitors, they're going to function through the renin-angiotensin pathway to try to reduce the work of the heart. Get the lipids down with statins or some other cholesterol-lowering drug. And then aspirin would be there for platelet inhibition to decrease coronary artery thrombosis. So these are kind of the most common meds that you would see brought on board after a cardiac event. So let's do our inspection. So we're going to start at the top and go down and start to figure out, start to take in the full clinical evidence of how our patient is doing. So upon inspection, they're alert and oriented ×3, good color, slightly overweight, kind of in that part of your brain where you're keeping track of cardiac risk factors. Patient resting comfortably, no visible signs of distress, no signs of peripheral edema. So can you answer why are we asking about peripheral edema? I think I had a heart attack, like what's going on there? So we're making sure this is our own checking of evidence of congestive heart failure. That we might be someone that would detect. It's also really important to observe the extremities and listen to the lungs before you move them, because if you get up and move them, that might be the first time that you're straining the heart, and they might go into some deficits in cardiac output during therapy. So if you want to see if those signs were there before you started. At rest, his dyspnea is 0. You listen to the lungs, no abnormal sounds, no crackles. This is kind of another check for heart failure if fluid has gone back into the heart. There's no abnormal sounds in the heart, no murmurs, and his blood pressure is 120/60. One thing I just wanted to note with these two, because in the case, they specifically already mentioned there was no lung sounds and there was no S3. That was kind of in our chart review that we did. It's really important to still listen for yourself. One, conditions can constantly change, especially in someone who's just had an acute cardiac event. A nurse that did a report this morning, and now you're coming in hours later, things could have changed. So even though you read that there's no abnormal sounds, you still want to listen. The other big thing is that you are about to get them up and exercise, as I mentioned with the peripheral edema. So you want to be sure what their status was right before this exercise challenge you're hoping to give them, so that if something changes, you are accurately reporting this to the medical team. When you palpate this patient's pulse, his pulse is 55 beats per minute, but you notice that it's irregular when you feel it. So you feel an irregular pulse, your eyes are going to pop up and look at their EKG. When you look at the EKG, this is what you see. So what do you observe on this patient's EKG? Clearly, there's some PVCs here. Finding of a PVC is not great. It's kind of a sign of some irritability in the ventricle. But there's something about this EKG that's even more problematic than just simply a PVC. The PVCs that we see have different morphologies. This means these are multifocal PVCs, meaning they're originating from different areas of the ventricle. So this isn't just one little area of the ventricle that's maybe a little irritated and firing off an action potential here or there. This is multiple spots that are irritated, so that's a more significant finding. So what do we do? What is the clinical decision here? We just went through, a lot of good stuff, that his laboratory values were in the good, all these findings are good. He has no dyspnea. He's not in distress, but his EKG looks like this. So the question is, are you worried? Am I worried? Is this worrisome? So whenever you encounter a new arrhythmia, you always ask the same 4 questions. Is this arrhythmia a new finding? And in this case, yes. There's no one reported anywhere in that chart review that we've seen so far. It was absent for sure on the cardiac ICU stage. They specifically said that it was unremarkable and there was no disturbance. Is this benign or life-threatening? Well, a PVC by itself is a benign finding. But they are occurring in the presence of known ischemic disease, and it's multifocal, so originating from 2 different spots of the ventricle. That can be concerning. The third question is, could the medications the patient is taking be producing this? And the answer is yes. Beta blockers can cause arrhythmias. So there's a chance this is kind of a side effect of his medication. And what are the severity of this patient's symptoms? And he's not having any symptoms. So there's no symptoms at rest. So what do we do? What is our assessment at this point? We know that a patient who just had an MI is extremely vulnerable to reinfarction and even potential rupture. So anything we might do, you want to proceed very slowly and cautiously. We're not going to jump to some higher level exercise at this point. But it would be very helpful if you can see what would happen to these PVCs during exercise. And PTs that work in cardiac rehab or in inpatient settings that are treating patients, after any kind of cardiac incidents, they do little mini stress tests all the my words just got tangled, all the time. It's not a formal test. It is not a formal stress test. But every PT session is like a little mini stress test. And during that test, you're going to be measuring and carefully assessing their EKG, their heart rate, their blood pressure. You can use heart rate and systolic blood pressure to get their rate pressure product to kind of get an assessment of their myocardial oxygen consumption. This can all be done in a typical PT appointment, and this could be really critical for this patient to see what would happen to these PVCs during exercise. The next question that can also be answered is, are these PVCs a potential sign of an occult myocardial ischemia? That means that there is actually ischemia happening without any signs or symptoms, kind of a silent ischemia. If you gave this patient an exercise challenge and the ST segment didn't change, they did not develop any symptoms, you could say that this was an absence of myocardial ischemia because you increased demand and didn't kind of reveal a greater problem. So the top of the next page of your notes, this is what the PT did. They had the patient perform some mild calisthenics to produce a modest increase in heart rate. They were kind of shooting for just less than 10 beats per minute above their resting heart rate. You kind of closely recording heart rate and blood pressure. And as you're increasing heart rate, you would want to record the rate pressure product where any symptoms of ischemia appeared or if there's any EKG changes. Because again, rate pressure product correlates very closely to myocardial oxygen consumption. So this can be an important threshold to know how hard the patient can work. When you keep track of the rate pressure product, it can be used to create a safe exercise program and just used to help keep the patient safe during any activity if they know kind of what their limit is by kind of heart rate and blood pressure. So in response to the mild increase in heart rate, the PVC frequency stayed the same, ST segment did not change its position with exercise, and the patient did not complain of any discomfort. So this is a great finding. With increased demand, the cardiac arrhythmia did not get worse. There's no new signs of ischemia on the EKG, and there's no symptoms. All right, so we can keep working with this patient and progress him. Over the next few days, the patient increased his activities from bed level through self-care activities all the way to ambulation, down the hall and back. He was taken off beta blockade and his PVCs went away. So the PVCs were a side effect of the beta blockers. I like that this happened in this case because it is challenging to know how safe it is to push patients. But this patient would have done way worse if he had laid in bed because the PVCs were there. You can safely assess, if you really proceed cautiously and do a good job monitoring vitals, and allow this patient to progress to walking without being held back by that side effect of the med. As the time of hospital discharge approached, the patient was able to walk 200 feet fairly rapidly at a heart rate not exceeding 98 beats per minute and a systolic blood pressure of 134. That gives us our rate pressure product without any signs of intolerance. On day 4 after the myocardial infarction, you introduce a stair challenge to prepare the patient for his home environment. The patient walked up a flight of stairs and complains of mild chest pain and palpitations. Because there's new symptoms, you terminate the exercise, you take an immediate BP, listen to heart and lungs, and assess the EKG response. This is the EKG strip immediately following the flight of stairs. So can you see what the arrows are pointing to? Immediately after the stairs, we're seeing ST segment depression, evidence, of myocardial ischemia. So you got ST segment depression. You record the maximal heart rate where this occurred. You record the blood pressure where this occurred. You're not noticing any new arrhythmias, no sounds, abnormal heart sounds, no crackles in the lungs, and the pain subsided within 2 minutes. So there's some good and there's some bad. Obviously, the bottom 2 are good. Pain subsided pretty quickly, and there's no new evidence. Let's look at this maximal heart rate of 140 beats per minute. Now, we're in phase 1, cardiac rehab. Did you guys oops, I'm going to write phase again. Hold on. Here we go. Phase 1 of cardiac rehab. What is the limit? Just remember the limit. What can you not go above? You have to stay within 70% of their heart rate max. That's that big ceiling where you don't want to go beyond that, because as the heart rate increases, you increase the work of the heart. So what is this patient's predicted heart rate max? Whenever doing this, you want to use the Tanaka. This is Cobwebs from Physical Activity. So 208 minus 70% of their age. This guy was 57. So his predicted heart rate max is 168 beats per minute. So 70% of that is 118 beats per minute. So this patient went way beyond the ceiling during this activity. So it does beg the question, why does heart rate go up so high? Like this, this is a bigger challenge, but this is a big leap. It seems extraordinarily high given that you were kind of progressing so carefully. So patients can get into trouble quickly because of this vicious cycle of cardiac insufficiency. With activity, you increase myocardial oxygen consumption. The heart needs more oxygen for the activity. But if there is some discrepancy and supply cannot match demand, you're going to end up in ischemia. When you're not getting sufficient blood supply to the tissue, this part we kind of just talked about, this can impact myocardial function and you can decrease myocyte function. They're not going to squeeze as hard because they're not getting enough oxygen, which can lead to the decreased stroke volume. And in the previous vicious cycle, we were talking about how with decreased stroke volume, I'll just kind of add this in over here, that means that you're going to decrease aortic pressure. And with decreasing aortic pressure, that's going to further limit the supply, right? Because the coronary vessels come off of the aorta. But in this activity vicious cycle, the decreased stroke volume is going to impact cardiac output. So the heart's going to try to maintain cardiac output to stay successful in the activity. Ooh. It's going to now that little thing threw my brain off. It's going to increase heart rate in order to maintain cardiac output. You don't have the stroke volume because the cells themselves are not getting enough oxygen. They're not going to be squeezing as hard. So the only thing you can do is increase the rate. But if you increase the rate, you increase the oxygen consumption. And around you go. And you can get into very high heart rates fast when someone starts to experience ischemia and the activity that's causing the increased oxygen demand is not stopped. So this can help to explain how high this patient's heart rate got during the activity. So with these findings, the patient was referred to the cardiac catheterization lab for a coronary angiograph. So whenever a cardiac catheterization is done, this is an invasive procedure, so it comes with certain risks. The patient is typically awake but under sedation. The catheter can be inserted into a peripheral vessel. So sometimes they use the femoral artery, sometimes they'll use the brachial or the radial artery, but they thread that catheter into the great vessels and then into the heart chambers under fluoroscopy, excuse me. All right, so general goals, it can be used to confirm or even establish a diagnosis of cardiac dysfunction. It can be very important to determine the severity of coronary artery disease or valvular dysfunction. And then it can help guide therapy and how they're going to manage this case. So you can get a ton of data when someone is in the cath lab. They can get cardiac output. They can look at vascular, shunting. If they add dye to the vessels, they can get a coronary or even a ventricle kind of imaging of where the blood flow is going. They can get pressures in all the different chambers. The catheterization has a greater predictive accuracy in assessing coronary artery disease than exercise testing. So almost everyone would get a cardiac catheterization before they have surgery. So they might do the stress tests as a baseline assessment and then do this prior to surgery because of the accuracy. If you see someone after a catheterization, if they went through the femoral artery, most patients are going to be in bed for 4 to 6 hours after the procedure. They're just really worried about the insertion site bleeding or developing what's called a pseudoaneurysm because of the place they went in. If it's brachial or radial, they might not be able to bear weight through that arm for 24 to 72 hours. So these are kind of the generic post-procedure guidelines. You really want to make sure that if they had a catheterization, you know any kind of limits that are put on by either the medical team or the institution that you're working at. So this patient's result showed a totally occluded right coronary artery and 90% lesion of the circumflex artery. His ejection fraction was only 45%, and he was scheduled for a coronary artery bypass graft of the circumflex artery. So this is a huge finding, and it's really important to think about the role of the PT in this case. The physical therapist came in and was getting this patient ready for the type of activity that they would be doing at home. They were able to protect this patient from injury and provided valuable information from the team. This patient was admitted with an inferior wall MI. So that's the right coronary artery. And now there's a new location, right? We now have a 90% lesion of the left circumflex artery. So at this point, this patient can undergo this CABG and it can save the lateral wall of the heart. So if this patient had just been discharged without being appropriately challenged within this safe environment, he could have had a full-blown loss of his lateral wall. So it is important that we push patients appropriately and safely while they're monitoring to the level that they're going to do at home for them to be safe. So I know this one's getting a little long, and I apologize for that. I'm just going to finish up this case. So a coronary artery bypass graft would be used whenever a PCI won't work, or if it's multi-vessel disease, because then you have too many places you're kind of trying to attack. So for the bypass graft, they can harvest a vessel from another area. It's common to harvest the saphenous vein, so then you'd want to inspect their kind of medial aspect of their distal thigh to look at the incision there. They can use the internal mammary artery, which is more kind of, now it's more commonly referred to as the internal thoracic artery. Basically, they just cut the distal end free and then anastomose it just below the coronary blockage. So you can use the original blood supply and just send it to the heart, which is pretty cool. Because you only have one on each side, an internal thoracic artery is limited to only 2 lesions on a CABG. The last one on your list there at the top of the next page of the notes, if you hadn't turned the page, is the gastroepiplotic artery, which is a newer option that's being used kind of more often. When an individual has a coronary artery bypass graft, they're typically on a bypass machine and the heart is stopped. So the heart can be still during the surgery and the blood is being circulated through the bypass machine. Some surgeons are now doing what's called off-pump CABG, meaning they're doing this surgery on a beating heart. It's really kind of up to the surgeon's training. There's some effects to there's some negative effects of the bypass graft when they reperfuse the heart. There can be some post-perfusion syndrome and some systemic inflammatory responses occasionally. But it's really what's being done at the institution that you work at will determine if they're on or off pump typically. So this patient had the CABG. It saved the lateral wall of the heart, and the patient was put back on beta blockade. PT treatment for this type of a patient after a CABG would focus on functional mobility, deep breathing and lung re-expansion because there was that big incision, patient education on their risk factors, their sternal precautions, active range of motion without exertion, and just really carefully monitoring for symptoms. So after the CABG, the patient was discharged to home without complications on day 4. And at this point, he would be referred to phase 2 cardiac rehab in an outpatient setting. All right, so that is the finale of that case. That sounds like a weird way of saying it. So we've completed the myocardial infarction case with a CABG. And thank you for attention. I'm sorry this one ran a little long.